Hemostasis is just a fast series of reactions that help stop the bleed, and it does need clotting factors and substances that are released by platelets and injured tissues as a whole. There's three stages of hemostasis: vascular spasm, platelet plug formation, and coagulation or blood clotting. The goal is to heal any vascular damage or to allow the blood vessel to recanalize or recanalization. So the first step is just a spasm, vascular spasm. When there's damage to a smooth muscle or to the endothelial lining of a blood vessel, it's going to lead to a myogenic spasm, a nervous reflex that leads to vasoconstriction of the vessel. So anything that directly injures vascular smooth muscle, certain chemicals that damage endothelial cells or platelets release, or nociception, pain reflexes, will trigger this vascular spasm. It's the most effective in small vessels. There could even be thromboxane A2 released by platelets here. And the outcome is to reduce blood flow to the area of damage until other mechanisms have taken place. Step two in this process is a platelet plug. Platelets will start to adhere to collagen fibers that are exposed when a blood vessel becomes damaged. A platelet will not stick to an intact vessel because collagen is not exposed. Prostacyclin and nitric oxide will prevent platelet adherence, and they are secreted by intact or healthy endothelial cells. This isn't just happening randomly in our body. And von Willebrand factor will stabilize platelet collagen adhesion. Once platelets become activated, platelets will swell, become spiky and sticky, and they then release lots of chemical messengers like ADP, which encourages platelets to adhere and secrete more chemicals, a positive feedback loop. And they'll also secrete serotonin and thromboxane A2, which enhances that vasoconstriction spasm, as well as enhances platelet aggregation. As more platelets stick, they release more chemicals, which causes more platelets to stick, and so on and so forth. This is a classic positive feedback loop. The extent of use, it's really okay for small vessel tears on its own, but for a larger main break, so to speak, it's not going to be sufficient enough. And this is just showing an image of kind of the platelet recruitment, adhesion, and activation and degranulation. Our stage three is coagulation, and this is really the process of blood clotting, which happens in three phases. The goal is to reinforce a platelet plug with fibrin threads, and blood will then also become more gel-like, more viscous. And this is really where it's helpful for a larger vessel break and where we get introduced to our clotting factors or procoagulants, mainly plasma proteins. They're numbered 1 through 13 in order of discovery, and vitamin K is needed for factors 2, 7, 9, and 10. When we look at the coagulation timeline, it's really 15 to 20 seconds begins in severe vascular trauma. By 3 to 6 minutes, we have an occlusive clot. This is unless a very large vascular defect is present. In about 20 to 60 minutes, we're dealing with clot retraction or breakdown. And then about 1 to 2 weeks later, we'll have invasion by fibroblasts and we'll have more organization into fibrous healed tissue. So with the coagulation cascade, this is what we're going to be going through, and we're going to break it down in pieces. And this is showing just the final formation of a fibrin clot. So we're first going to focus on this phase one intrinsic pathway. So that's where we're going to be focusing our time first. And we're going to kind of walk through a few components here. Clotting factors, it's important to know, are already in the blood, present. So if we have trauma to the blood in some way, that can trigger these clotting factors. They are specifically triggered by negatively charged surfaces. So a platelet that becomes activated, collagen, factor 12, glass, all these things could potentially trigger these inactive clotting factors over here to become active. So with the intrinsic pathway, we see that kind of our steps are 1, 2, 3, 4, 5. Okay. So we have some kind of blood trauma or contact with collagen that first starts to activate factor 12. That's the first factor to get activated. Then we can see that with some other components, factor 12 will act on factor 11, activating factor 11. With calcium being present, Factor 11 will activate factor 9. And then, and also factor 8 needs to kind of be around. Factor 8 will become active via thrombin, and then activated factor 9 works with activated factor 8 and calcium to activate factor 10. This is also where platelet phospholipids come to play. Once we have activated factor 10, we're going to go down the common pathway, which we'll talk about shortly. So this is where it would stop. So really you need to know just order of operations, the intrinsic pathways, something's going on with the blood, some trauma to the blood or contact with collagen. And we have factors 12, 11, 9, and 8. All of those work together to then activate factor 10. And then know where there's calcium involved, those calcium dependent steps. Now, looking at this extrinsic pathway over here on the right, these factors are located outside of the blood. They're not just hanging out in their inactive form in the blood. Therefore, there needs to be some kind of trauma to the vessel wall and tissues to initiate this factor. And that's why we say it's triggered by tissue factor or factor 3, which comes from the walls, the vessel wall, or from the tissues. It is a faster pathway because it bypasses some steps overall. So if we look at the extrinsic pathway, some type of trauma to the tissue will stimulate the release of tissue factor. Tissue factor or factor 3, it's important to know this is also factor 3, will then essentially activate factor 7. And factor 7 and 3, along with calcium, will activate factor 10. Factors also, factor 3, along with factor 10, along with calcium, can activate prothrombin activator, which then can activate prothrombin. Okay, so this is kind of how that connects, but that's common pathway. So what is prothrombin, right? This prothrombin molecule here, this is an alpha-2 globulin. It's vitamin K dependent synthesis in the liver, and it's cleaved by prothrombin activators to thrombin. So in our phase 2 pathway, we take prothrombin 2 to thrombin 2A, our active form. And prothrombin activator catalyzes this transformation. Once we have our thrombin 2, we can convert fibrinogen, soluble, to fibrin, which is an insoluble polymer. Fibrin can then create these strands that form the structural basis of a clot. And fibrin causes plasma to become very gel-like, capturing or catching formed elements. And then thrombin, along with calcium, will activate factor 8, which is fibrin stabilizing factor. And that creates cross links between fibrin to strengthen or to stabilize the clot. Fibrinogen itself is synthesized in the liver and it can act as an acute phase reactant, raising up with inflammation or pain states in the body. It typically is seen intravascular, but can leave the vasculature with increased permeability. So thrombin protease cleaves 4 small peptides from fibrinogen. This gives a fibrin molecule, which then undergoes spontaneous polymerization. Fibrin stabilizing factor is located in the plasma and released from platelets, and it's activated by thrombin. The covalent cross-linking of fibrin monomers and fibrin fibers are part of what fibrin stabilizing factor is doing. It's creating these cross bridges.